ado, I want to introduce you folks to my dear friend and colleague. Tino, are you ready? We're good to go? Awesome. So I had the honor of meeting Tino last year in California, but we had been connected before then. She is truly a gift to our field. Tino offers a critical perspective. She is a bilingual speech-language pathologist who's done most of her training in the medical realm. And I think the best thing about Tino is that she always gives a resounding yes to any opportunity to learn. And she's also really generous in sharing her knowledge. And so Tino's going to share a talk that she actually used to educate me when we were working together a little bit about differential diagnosis of dysarthria in rehabilitation and acute care.
Yes. Awesome. Okay, let me jump in and start sharing my screen. Can everyone see that? Yes, no?
Yes, we can see it. Tino is perfect.
Awesome. Okay. All right. So I'm going to keep it just like this. Sorry if it's the top part where you can see my tabs is a little distracting, but I need to be able to see some of my notes. So I have to keep it like this. But without further ado, we're going to get started. Thank you, Amy, for the really kind introduction. Like she said, this session is titled Differentially Diagnosing Dysarthria in Inpatient Rehab and Acute Care Settings. And like you said, my name is Tino. I'm originally from Zimbabwe, bilingual speech-language pathologist in the medical realm of things. Some of my clinical experiences I figured would be helpful to kind of tie into why I chose this topic. So I have experience working in inpatient rehab / skilled nursing facility. In my grad years, I worked outpatient at our adult speech clinic and then was also part of our mild traumatic brain injury program with our student athletes. I've had experience working school-based with some of our middle school and elementary kiddos, and then of course acute care just on the gen med side with some observations in the ICU. So I was also really interested about that. So, you know, what's most pertinent was my experience working inpatient rehab / acute at a trauma 1 hospital. And this was where I really had my eyes opened about the importance of the quality of our care across the continuum of care. So I was seeing patients acute and then having them come over to our inpatient rehab unit where I was mainly stationed. And I was noticing that dysarthria in many ways was the underdog of the profession, especially in these high intensity settings. I was seeing patients that were referred over to my unit, often with inaccurate or incomplete dysarthria diagnoses. And working in a safety net hospital, which is where I was at, often this was the most care that most patients would get before they returned to being unhoused or in prison or in low-income housing. And so it made me really wonder how holding back these diagnoses would affect the patients as they went further along the care. And it also showed me just how much ignoring this motor speech disorder, often due to lack of time, sometimes lack of experience, had led to a gap in care. So this presentation began as my capstone project in my clinical fellowship year, where I educated my colleagues on differentially diagnosing dysarthria to help refresh their knowledge and also to help challenge me, myself, and my patient care as well. And so I've developed it further for me to share today because I feel it's an important topic. And I hope that it can also kind of refresh your knowledge and help you as well within your care. So I'm going to start off with disclosures. I have no financial or non-financial disclosures. Also, I can't see the chat box, so I'll need to hear voices. This is going to be a little bit of an interactive session. So when I'll ask some questions along the way, and when I do, I would hope that we can jump in just a couple of people here and there, just giving input. And if anyone drops anything in the chat, please, Amy, if you kind of hop on and just like read out loud what you're seeing on there, that'd be also really helpful.
Absolutely, no problem.
Awesome. So we're going to start with just laying out our learning objectives, right? And so there's two main learning objectives to this. The first is that you would walk away with a new or refreshed ability to connect the neurologic deficits that you're seeing to motor movement and speech deficits in order to arrive to an accurate dysarthria diagnosis. The second is that you'd be able to then incorporate dysarthria assessment to your already existing dysphagia, language, or cognitive assessments so that you can keep up your productivity, so that you can hit all the other important aspects of what your patients need. And you don't slow yourself down, but you also you bring in that underdog deficit, as I like to call dysarthria. So we're going to jump right in. This is Bill. Bill will be our main case study for this. And so we're going to discuss him, and at the end, we're going to actually diagnose the dysarthria that he has. And so Bill comes into your hospital. You've gotten a speech eval request for him shortly after he arrives after a stroke. This isn't Bill's first time at the hospital after having this stroke. Previously, he was admitted with an NIHSS of 4, which is a minor stroke, and he even had left facial palsy. Just looking at his chart history a little bit as you're rushing through, you've got a bunch of patients, you see that he has a history of hypertension, vertigo, diabetes, and then obviously the stroke piece, but you don't get to quite jump into the CT or MRIs to really see what's going on. So you arrive to the room, and immediately as you're talking to his nurse, they're letting you know that he's very frustrated. Has incredibly low intelligibility, so he's not able to effectively communicate. And so he's confused, he's frustrated, his adult daughter is there with him. And so she's also wondering what's going on. This is not his baseline function. And so she's also kind of has questions as well. And so for the sake of this presentation, we're going to look at him in a vacuum and not really worry about the dysphagia piece or the cognitive or the language piece. We're going to assume that all of those things are within functional limits. And we're really going to zone in on his motor speech. So after you walk in with him, of course, you can always do, if the nurses haven't, just give him a low-tech AAC just to help him even communicate with you during the session and to even communicate with his care team after you're gone, like his nurses and other doctors. And so you do that. However, you also want to provide this family with answers. You want to give the daughter an answer of what's going on, and you want to give them specifics so that they can just understand what's developing with him. And because you were rushing and you didn't really get to see his chart, at least to look at his MRIs or CTs, or if there's anything that's been ordered with neurology, you do a quick speech assessment at bedside. And what you hear is that Bill has drunken scanning speech. His sounds very slurred. It's very hypernasal, like harsh tone. He has that decreased rate of speech, end of vocalization grunts that at the end of every vocalization, he has some volume variation as well. So here's where we jump in with a quick yes or no, either in the chats or you can unmute yourself. But can we diagnose Bill's dysarthria based off of the info we have, which is really that he has a stroke, that's all you know, and then what you've heard with his speech characteristics. Is this sufficient information for us to make an accurate diagnosis?
Could you say that he has dysarthria but not characterize the type?
Yeah, so we could give that he has dysarthria, but we don't know what types. But could we differentially diagnose it? Do we have enough information to say, I know exactly what dysarthria he has, just based off of having our speech characteristics? No, we can't chat
back. A resounding no, Tino. Everyone says no.
Yes. So I wish I could see the chat box somehow. I don't know why this is. Hold on, because I would love to do that. Just a second. Oh yeah, I can see the chats over here. Okay, cool. I can make it hover just like this. Nice. Okay, awesome. So no, we cannot. And so what crucial information is missing that is important for us to make sure that we have an accurate dysarthria diagnosis? So what are some things we'd need to know on top of his speech characteristics? I'm gonna wait. Yeah, his lesion site. So that's actually one of the main things that we would want to be looking out for is the lesion site. If there's anything that we walk away from this presentation with, is that lesion site is really the main deciding factor for differentially diagnosing dysarthria. It's lesion site and it goes hand in hand with the etiology. So sometimes it's really just you start off with understanding the etiology, which then lets you know what what part of the CNS has been affected, which is the lesion site. And that is the thing that you can stand on. That is the evidence that you have as to why everything else then falls into place of what this patient has when it comes to actually accurately differentially diagnosing dysarthria. And so we're going to do a quick activity. So I'm going to need people to unmute themselves. I don't know if you have the ability to do that, but we will either unmute or chats, but please more people in the chats. So we're looking at this. I've got this chart up for you guys, and I really want to drive home why just listening to our auditory factors is not enough for us to make an accurate dysarthria diagnosis. And so looking at this chart, you're looking at the types and you're looking at the auditory signs. Which dysarthrias are you seeing that have nasal or hypernasality as an auditory sign? So there's 3 of them. So once those 3 are said, I'll go on to the next slide.
Can you repeat the question, Tino?
Yeah. So which dysarthrias have nasal or hypernasality as an auditory sign? So just looking at that this third column right here. If you see nasality or hypernasality, then you kind of connect it with which dysarthria. Can you guys let me know what you see? Spastic, yep. Flaccid, and yes, unilateral upper motor neuron. Thank you, thank you, thank you. So there's 3 different dysarthrias that all point to hypernasality as one of their auditory signs. Now imagine you walk in and maybe the patient's nasality is resounding on top of everything else. And you know that flaccid dysarthria is often connected to nasality, right? And hypernasality. And you just think it's flaccid dysarthria. You're going to miss what could actually be the accurate diagnosis because of the fact that it could still also be spastic or it could be unilateral. And so this is just one of the ways that we can really see the importance of looking back to lesion site and looking back to etiology. We're going to do it one more time with a different auditory sign this time. Which dysarthria, as you're looking again at the column, have decreased rate as an auditory sign? So there's another 3 as well. Which dysarthrias have decreased rate as an auditory sign?
Spastic, unilateral upper motor,
and
Flaccid.
So if you look, it should be the very last one, unless I missed something. But it's
spastic and flaccid.
Right, spastic and flaccid, and then really mixed, which is still mixed spastic and flaccid, right? And so we're seeing in those 2 main ones that they have that decreased rate. And these are ones that, you know, are often kind of just like, well, actually did I do it right here? So yeah, so here I have decreased rate for spastic and unilateral, and then for a mix of spastic and flaccid. And the reason being that the spastic in that mix is the one that has decreased rate. So of course, like I said, our dysarthrias have their hallmark features. Flaccid does have nasality as its hallmark feature. Spastic and unilateral upper motor neuron dysarthria have that harsh tone. Ataxic has the drunken speech, etc. But to rely solely on that, like I said, on just what we're hearing is a surefire way for us to start heading the wrong direction. It would be the same as us diagnosing dysphagia at bedside, just based off of what we're seeing at bedside, without actually doing a FEES or without actually doing any sort of imaging. We're just going in blind at that point. So the question is, what do we do? Well, we learn our neurology or refresh ourselves to that, right? To be able to streamline the process. And we start to piece together our diagnosis based on multiple things using the E.L.M.S analysis. What is the E.L.M.S analysis? E.L.M.S stands for etiology, lesion site, motor function, and speech deficits. This is an analysis that the earliest article that I found was by Paul Blanchett in 2013, where he talks about it. And it really is a system that allows you to look across everything that you need to know in order for you to make an accurate dysarthria diagnosis. And sometimes we may be tempted to just focus on speech or focus on the lesion and the speech deficits, but it's important for us for all 4 of these to fall into place in order for us to have a diagnosis that is backed up by evidence and also can be presented in the patient's history and their presentation, right? So I've had doctors ask me, like I had a doctor ask me to come see a patient in the psych ward, and the patient was presenting with schizophrenia. In the doctor's note, they already said, patient has dysarthria. And so they're asking me to come in for a speech eval, I guess, to just confirm that. And I come in there after the chart review. There's nothing that's really showing, no CT, MRIs, nothing neurology-wise that was standing out. I come in and I do the assessment. I'm looking at the motor movement. I'm listening to their speech. I'm thinking back to what I saw in the chart on there, if there was any lesion sites, and I'm not seeing anything. All I hear is a disorganized speech. All I hear is some mumbling. All I hear is low intelligibility. Well, schizophrenia already has disorganized speech as one of the things that might occur as a result. So this is really just a speech deficit. And so in that moment, knowing what I know and knowing that I need all of those things to check out, I was able to educate the doctor and be like, hey, so what we have here is a patient. Uh-oh, did I get muted? Oops. So where did I lose you guys? So you heard about the psych ward and the schizophrenia, the patient with schizophrenia?
Yeah.
Yes. So you educated the doctor. What did you educate the doctor on?
So educating the doctor on the fact that if there's nothing that I'm seeing with the etiology or lesion site that really points to a neurologic insult or something that would lead to a dysarthria, and everything that I'm seeing with motor function, speech deficits, that there's just not enough evidence there for me to say it's dysarthria, but rather just to say, yes, this patient does have some speech deficits, likely something like a disorganized speech, likely something that's connected to their diagnosis of having schizophrenia as opposed to it being a dysarthria. So that was a learning moment for that doctor. And we can be those people that advocate in that way for our patients if we know that we have this analysis, we have this frame, and we utilize that frame to be able to make sure that we're giving accurate diagnoses and just shedding that light. And so then the big question is, why differentiate? Why can't I just say, okay, patient presents with dysarthria, patient presents with speech deficits? Especially if I'm running around, I have to keep up my productivity. There's so much going on. Often patients have dysphagia, have some cognition issues, have some language issues on top of dysarthria. It's just not at the top of my list of things that I need to attack unless it's like so severe, right? Well, there's a couple of points that I've written down here just to try to convince you or to try to just get you on board or have an open mind to that in case you're that kind where it's like, it is important for you to look at their nutrition. It is important for you to look at their language. It is important for you to focus on cognition, but it's also important to not only say dysarthria, but to differentiate because that affects so many other things. So the first thing that isn't on our slide is the fact that the treatment of our dysarthria has to do with knowing what kind of dysarthria it is. The treatment is not going to be one size fits all because dysarthria often affects different systems. So your respiration, your phonation, your articulation, your resonance, and your prosody. So what you will do to help your patient who has issues with their phonation is not going to be necessarily the same as if their issue is their resonance, right? And so it's important for you to know what kind of dysarthria, because then you know, okay, these are the characteristics they have. Okay, then this is the system that I'm now going through. I'm going to focus on their breathing. I'm going to focus on their loudness. I'm going to focus on their artic. We're going to focus on this. So being able to know what kind it is and to lay it out is also important for that. And then the first point that I have on here is from Duffy in 2008. And he talked about how diagnosis plays a critical role of helping localize and diagnose neurologic diseases. So something like an ALS or something outside of just saying a patient has stroke. If they don't have a stroke, they might have something else that's neurologic and affecting their motor speech, essentially. The one thing I disagree with this paper, and it is an older paper, is in the paper, Duffy really focuses on listening to the speech and then somehow coming up to being like, oh, the patient had ALS. But we already know that we need so much more to be able to get the evidence. We need to look at their etiology. We need to look at their lesion. We need to look at what their motor is doing. We need to look at their speech because all those things are connected and all those things will help give us a solid foundation. But because once we kind of get a grasp of all those things, if a patient comes in and they're not really coordinated, but the CT of the head is the only thing that's been done. There's no MRI. And you're thinking to yourself, okay, they lack coordination, but from my knowledge of neurology, there should be something happening, maybe extrapyramidally. Okay, so it might be a cerebellum or basal ganglia thing. Okay, so maybe they could do an MRI. And then you reach out to the doctor and kind of check, hey, is there an order that's going to be put for an MRI? Because I'm seeing some stuff. And often PT might also be seeing ataxia. They might be on there just saying, okay, it's just showing that they might have ataxia and they're having trouble with their gait. And so then you're a part of the larger conversation just for knowing that and just being able to differentiate with that. And then the second note is we're able to be efficient and provide personalized care further down the continuum of care. This is so important because in your trauma 1, trauma 2, in those hospitals where you have all the resources, you can just ask and get orders done and get patients into rooms and get their imaging done and talk to their care team and all of that. You're surrounded by so much support that there's somebody in a rural SNF that's going to receive this patient and they're just sitting there with holes in some of the notes and no direct access to you or the rest of the initial care team. And all you wrote was, okay, patient presents with dysarthria, and they're thinking, okay. So now they're having to do a mound of work just to kind of get the information that we could have provided them if we had just jumped in at first and given all of that. So just thinking about further down the continuum of care, further down the line. And then the third is we want to contribute information to the rest of the care team, right? That either confirms or brings into question what's being observed. So we kind of talked about that as well. And the last is bolded in black there. We are the pathologists of speech. Our role is to diagnose. It is our job to diagnose. And so the reason we have that title is so we can make those differentiation. And so whenever we can, we should. And the way that we can do that efficiently is to do stuff like this and really learn how to streamline our processes and get all the stuff done. So when you go in there, no part is neglected and we're able to get through all of the different things we need to do with our patients. So all of that being said, we're going to jump into the neurology refresher here. So what's really important when it comes to diagnosing dysarthria is really getting a good grip of our neurology background knowledge, at least as it pertains to these key elements of the upper motor neuron system, the lower motor neurons, aka the final common pathway, and then the extrapyramidal tract system. Okay, so we're going to jump into the first two. So really learning the difference between the upper motor neuron and the lower motor neuron. So I'm going to play this brief video. And it's 3 minutes. I cut it at 3 minutes, just so he's just talking about the difference between upper motor neurons and lower motor neurons. Let me know if you can't hear it.
In this video, we will talk about motor disorders.
Oh, hold on, just a second.
And what
I think it's not started here.
In this video, we will talk about motor disorders. And what I mean by disorders is disorders affecting somehow your skeletal muscles, your voluntary muscles. We'll be comparing upper motor neuron lesions to lower motor neuron lesions and what each of these mean. In order to understand upper and lower motor neuron lesions, we must recap the motor pathways, looking at the pyramidal system, which is the system of voluntary movement. Normal motor function depends on the transmission of signals from the brain to brainstem or spinal cord by the upper motor neurons, and then from there to skeletal muscles by lower motor neurons. Here is a cross-section of the primary motor cortex of the brain. The outer gray matter of the cortex have areas where neurons arise from, which are associated to a particular area in the body, so the feet, hands, and the face. The white matter consists mainly of neurons' axons, which travel through the brain. Motor neurons will pass through the internal capsule situated near the thalamus and basal ganglia. Here is a brainstem, which is made up of 3 parts: the midbrain. Important area here is the red nucleus and crus cerebri, and the pons, not drawn, as well as the medulla oblongata here. Here is a cross-section of the spinal cord where the communication between upper and lower motor neurons occur. We will learn about this soon. The spinal cord have tracts, which are where neurons travel through. Important tracts in the pyramidal system are the lateral corticospinal tract and the anterior corticospinal tract. The target organ of the motor neurons are the skeletal muscle cells. Let's create a scenario where we want to move our right thumb. The upper motor neurons arise from the left primary motor cortex, pass through the internal capsule, through the brainstem, passing the crus cerebri, passing through the pons, and then passing through the medulla, the area called the pyramids. Hence, it's called the pyramidal system. The vast majority of upper motor neurons that project from the motor cortex to the spinal cord are contained in the lateral corticospinal tract. The neurons that will travel through the lateral corticospinal tracts will cross over at the medulla of the brainstem. Once the upper motor neurons reaches the correct spinal level, it will synapse with the lower motor neurons at the anterior horn of the spinal cord. The lower motor neurons will then target the skeletal muscles responsible for movement of that body part involved. So in this scenario, it is the muscles involved in the right thumb movement. Majority of upper motor neurons.
Awesome. I did this before too, so hold on just a second. Technology, it'll just work crazy as soon as you're in front of people. There we go. So we're going to go to the next slide. Let me open this up. All right. So like we saw in the video there, the upper motor neurons then are essentially just the neurons that control the motor activity of the body. So their cell bodies are in the cerebrum and the brainstem, and they initiate that voluntary movement by communicating with the lower motor neurons. And so one of the main things with the upper motor neurons is that they maintain muscle tone. Muscle tone is that resting tension in your skeletal muscle. The reason muscle tone is important to us as speech therapists is because a lot of times when there's damage to the upper motor neurons, that muscle tone, the way that it's maintained is the upper motor neuron essentially sends and gives this facilitatory and inhibitory functions that then maintain the muscle tone. So it tells the lower motor neuron, hey, okay, increase on that facilitatory, okay, increase on that inhibitory, and that is what maintains your muscle tone. Now, as soon as there's some disease or disruption with the upper motor neuron, you'll find that that inhibitory part of it is then cut off. And so the lower motor neuron is just getting these facilitatory functions, right? And so it keeps adding, and that results in that overactivity. And that results in that hypertonia and that spasticity. And so when we then naturally see that the dysarthrias that are attached with the upper motor neuron damage are spastic and unilateral, we can understand that because now we know that when that damage happens, you're getting all that facilitatory signals, right? And that's what's creating that spasticity, that tone. And the reason that is so important is because not only does it affect just hearing that harsh tone, you're also seeing that a patient struggles sometimes with their respiration because of that compression and that tension. They're not able to really support even their voice, right? So decreased volume. Why? Because they're not able to get enough pressure and respiration to really push their voice out, right? And so there's all of these things that all work together, and it all starts with the disruption to the upper motor neuron. Now, there are two types. There's bilateral upper motor neuron damage, and that's usually more diffuse damage that affects, both hemispheres, and it's called bilateral for that. And then we've got the unilateral, which often it's maybe, I won't say often, but it's due to more of like a focal damage, something like you get hit, it's focal in one part, maybe a tumor's right there, something like that results in a unilateral. The main differentiation for you to look out for is that often it's one side. I think the lower central part of your face on one side will droop when it's unilateral, as opposed to when it's spastic. So that's what I've read to be one of the helping factors to see if you're still unsure. Is it unilateral? though I've rarely seen unilateral. I don't know how much more common it is or less common than spastic, but I assume that spastic might be a little bit ahead of the game with that. So like the video said too, with lower motor neurons, those are the ones that are, they start off at the spinal cord in the anterior horn of the spinal cords. We've got those different levels of the spinal cord, and each one has that anterior horn, and each one has the lower motor neuron cell bodies in there. And they're the ones that are synapsing with the upper motor neuron, but they're the ones that really carry that final message, which is why the lower motor neuron system is known as the final common pathway. Why is that important for us to know? Well, because it's receiving information from the upper motor neuron, and because it connects to the muscles. Whenever we see paralysis or paresis, our brain should already be firing on the fact that it is something to do with the lower motor neurons being damaged. And so you could go into your chart and you could see that there's a lesion. You could see that it's maybe due to a stroke, maybe it's affected a certain area of the brain, and it could look like a bunch of jargon. Often I go in there and they're like, carotid this, L1, M2, and it's a lot of words for, there's damage to some part of the cerebrum. I'm already thinking diffuse damage. I'm thinking, do I think it's affecting the upper motor neuron or the lower motor neuron system? So you take that knowledge, and then that's why it's important to have the E.L.M.S, because then you're looking at motor function. Oh, okay, I walk in, I'm like, hey, Mr. Johnson. Mr. Johnson's waving at me. Mr. Johnson's legs are all good. Mr. Johnson's arms are fine. There's no anything that could indicate to me that Mr. Johnson has issues with moving his limbs, and his face is symmetrical for the most part. And so I'm not thinking lower motor neuron anymore, right? And so I'm immediately like, oh, it might be an upper motor neuron damage, right? I've seen nothing else. It might be that. So that's the way that you should be thinking through this. And that's why it's so important to understand the neurology from this perspective. So like I said, the dysarthria with this is that flaccid dysarthria. Okay, so you will hear that nasal voice, a breathiness, really a lot of, just because there's just such weakness and lack of movement, because it is the lower motor neuron damage. Often I think even with breathiness, it might even have to do with our vocal folds, and maybe a paralysis, one of them, or a lack of adduction, but don't quote me on that, but just using kind of my just educated guesses. So this is the last part of our neurology refresher, right? So we're going to look at the extrapyramidal system, which has the last two main systems that we need to know in order for us to complete the picture of our dysarthrias. But in order for us to really understand the extrapyramidal system, we need to know what the pyramidal system is. So the pyramidal system is essentially what, that controls the voluntary movement. So as we were talking about upper motor neurons and connecting to the lower motor neurons and initiate and voluntary movement, like all of that, that's the pyramidal system. It really is about controlling voluntary movement. It includes the cortical spinal and cortical bulbar tracts, and it's named after the pyramids right here that are in the medulla. And so that's one thing you should just know. The pyramidal tract is about voluntary movement. It includes upper and lower motor neurons. The extrapyramidal system also includes upper and motor neurons, but there's a little bit of more fun that happens there in the middle. The extrapyramidal system is really about the involuntary automatic movement. So without you thinking right now, your posture, you're sitting up, you're not having to put too much effort or thought into your posture against gravity, right? That's your body doing it for you. You're blinking. That's your body just doing it for you. You swallow your saliva. That's your body doing it for you. That's all the extrapyramidal system. It is involved in all of the involuntary and automatic movements. And this is also important because when you see that the extrapyramidal system has the basal ganglia and cerebellum as their nuclei that are involved there, well, we already know that patients with Parkinsonism, so patients with what we would call, I think it's a hypokinetic dysarthria, this would be because something's up in their basal ganglia, right? And so because something's up in their basal ganglia, well, that system that usually fine tunes the movement, that usually helps with all of that, the automatic, it's being affected. And so when patients have Parkinson, their dysarthria kind of shows up as that reduced volume. And if you've done speak out and loud crowd training, then you know that the thing that they're pushing is speak with intent. Why? Because you want to bypass the automatic and go straight to your voluntary system. You want to go straight to that pyramidal system and start getting it moving so that you can get your loudness back and gain some of the things that you're losing based off of what's going on with your basal ganglia. Okay, so really, again, the extrapyramidal system has just extra stops in the system. Impulses travel through from the upper motor neuron, travel through that. They're kind of fine-tuned there and then go down to the lower motor neuron. And a little bit more to know is the basal ganglia is the one that initiates that motor movement, and the cerebellum is functions to coordinate that motor movement, right? And which is why it would make sense when we're looking at the damage to the cerebellum. Well, if it's helping coordinate motor movement, it's doing that through the extrapyramidal system. Well, I'm surely going to see uncoordinated speech. I'm going to see some scanning. I'm going to see some irregular articulatory breakdown because the patient's having a hard time with coordination. And, you know, as you see these are more structures that would be more visible in our MRIs, as we know. So you're looking at the MRI being like, okay, what's going on? And I've had patients come in before and they are presenting with dysarthria. And this is actually a colleague of mine. She actually ended up calling me. She's like, hey, you know, I'm looking at this patient and they seem okay, but they're still having trouble with their coordination. But, you know, all I have here is a CT, and on the CT, we're not seeing much on the CT and nothing else has been done. But when I'm listening to them, I'm seeing all of these different things. So I'm like, oh, okay, why don't we have the doctor, why don't you ask them if they've sent in an order for an MRI? And so that's what she ended up doing. They're like, actually, we were about to do that. We're about to send for that because they're not only is it happening with the speech, it's obviously going to show in other parts of the patient as well, right? And so again, that's why it's so important for us to know these so that we can spot and we can even help our care team and help ourselves get a better diagnosis of what's happening. And again, all of these things would still tie to some of what's going on with swallow, right? If you're having trouble coordinating, even just talking or even just getting your food down, that's still going to, you know, affect what your swallow is doing. So all of this stuff is really pertinent to all of the different functions and stuff that we're looking at. So now it comes time to discuss, okay, how do I get all this information? As I'm sitting there and I have like 10 patients I got to see and 2 new evals and I'm chart reviewing and I'm running around and I need to get all my units and all of this stuff. How do I make sure that, okay, I want to differentially diagnose, I want to do it accurately. How do I get it into the time that I have? Because I still think, you know, dysphagia is more important because nutrition is important. And I agree. Or getting their language and the communication, that's important. And I totally agree. Well, just looking at it from a dysphagia point of view, these are some of the ways that we can incorporate our dysarthria assessment into our dysphagia. So let's say you go in, you're doing a clinical swallow eval. If you're looking at their oral mech, right? You're identifying the lingual and labial movements, stick out your tongue, move it side to side. Not only are you doing that for their oral phase, but now you're kind of looking at the coordination too, especially if you've already seen that something might be going on in their MRIs or you're suspecting some issues with coordination, then you're seeing that. Then, of course, the AMRs, those are aside from what you might be doing with dysphagia, but it would still be easy to slip in. Hey, could you just go ahead and just go pataka, pataka, pataka for me? On top of that, you're seeing how well do they follow directions if you're still also trying to see what their cognition is like. So then they're going through the patakas and you're able to even hear their speech while also understanding how well they can follow that direction, right? Then during PO trials, you're utilizing that time in between when as they're swallowing to kind of just ask a couple questions here and there within moderation. Obviously, some of them you don't want to talk and eat at the same time, especially if they're more acute. So you can just whatever fits well, just get some conversation in there, build rapport while also listening to their speech characteristics. And then we're going into during the PO trials. Well, we already said that, but now in the motor movement, right? So like I said, I go in and I'm just like, oh, hey, Mr. Smith. Okay, wave your arm for me. Okay, go ahead. Can you wave your other arm? Okay, awesome. Can you just raise your leg for me a little bit? Oh, and your other leg? Okay. And I'm already doing that just as I come in before I even say anything. And then I could also even check in with PTOT. And again, all those things like wave your arms, like, can I have a thumbs up? Like all of those things could still be following one-step directions. If you want to add on that cognitive load, okay, why don't you raise your arm and then point to the door? You're still doing the cognitive piece while also looking at the patient's movement, right? And looking at what's going on with their movements. And so that's just some of the way. Of course, there's assessments such as the MOCA, which is good for cognition. If you have the certification to kind of go and do that. And there's always spots in there to not only listen to their speech, but also just kind of go through the cognition piece while keeping in mind some of their speech. Of course, there's things like Differentially, which is this whole formal dysarthria assessment. And, you know, that's cool, but it takes a long time. Unless you're outpatient or you have way more time, you're not going to be able to do that. And so you're going to have to look for informal ways to capture the 4 things that you need, right? The looking at their etiology, looking at their lesion site. And then now you're really focusing on their motor and you're focusing on their speech. And so that's just something to keep in mind, is that even if it is a language and you're doing, let's say, a bedside Western aphasia battery, just try to look for places to plug in all of those things that you might need with your dysarthria. You can use stuff like the grandfather passage as well, if you really still are wanting to look at the patient's ability to read, right? To be able to have that language comprehension and their ability to even express their language. That is all ways that you can incorporate your motor speech assessments into, whether that be language or it be your dysphagia or your cognition. Okay. So now it's time for us to diagnose Bill. So this is kind of like the final portion. I feel I've moved a little fast, but it's okay. But this is going to take us a little bit. We'll just kind of talk through it slowly. And so, you know, after everything that we've talked about, looking at how to jump into our neurology, how do we piece all of that together? How do we jump into the motor stuff? How do we talk about the speech deficits? I hope that now, as we're going through this final part of this, where we're really looking at Bill from all angles when it comes to his motor speech, that it starts to make a little bit more sense. This is where it becomes a little bit more of the interactive, whether that be via chat or if you want to quick unmute and then mute yourself, right? So here is what Bill's TT results look like, okay? So he had no acute hemorrhaging. He had moderate to severe stenosis involving his RMCA and his LMCA, and then a bunch of those letters that we don't really know what they are, but I've already seen 2 main things that at least make sense, that could give me an idea, right? Because the MCA is a big distributor of blood flow to the cerebrum, okay, and multiple other parts. And so that's already ringing a bell for me. So as you're looking at that there's severe stenosis involving RMCA and LMCA, which key elements are you thinking about when it comes to lower motor neurons, upper motor neurons, or the extrapyramidal system? There could be even a couple. Which systems do you think could be affected by this stenosis involving the RMCA? So between the lower motor neurons, it could be any or all of them at this point, right? But because we're looking at that main one, could be any or all, but the first 2 that come into my mind immediately, because we're not going to really see what's going on deeper into our cerebellum or the basal ganglia until we look at our MRI results. So here I'm really focusing on that cerebrum and that area of the brain. I'm starting to already think, okay, maybe something with the upper motor neurons, maybe something with the lower motor neurons. Okay, so that's something for us to keep in mind as a potential of a place that's being affected, right? So when you look at your MRI results, now you're seeing, okay, he also had acute ischemic strokes involving the left cerebellar hemisphere. So when we read that immediately, what structure is it pointing us to as something that's been affected then? Right, as we read that MRI result. What's the part? Is it the basal ganglia? Is it cerebellum? Is it the upper motor neuron? What's the part that's been affected as we read that? The word is in there.
Cerebellum.
Cerebellum.
Thank you, Samantha. I'm like, oh, am I alone? I can't see anybody. But yeah, so the cerebellum. So now we got 3 potential things going on. For sure, it's been confirmed from the MRIs that something is affecting the cerebellum, right? So at least we know that going in. That could help with our diagnosis already. And then now we know that something's happened with the CT results that's showing us that a very major blood vessel on both hemispheres, both left and right, has been blocked or affected. And so it's a diffuse damage, right? Because the blood flow is going everywhere. Now it's kind of just like on both sides been affected. So it could either be an upper motor neuron disruption, or it can be deep enough for it to also be a lower motor neuron. And so, right. So then now going into it, if we wanted to know, is it just the upper motor neuron that's been affected, or is it the lower motor neuron and not the upper motor neuron? What's a deciding factor that help us, that we've just learned in terms of the function, right, of the upper motor neuron or the lower motor neuron? What's one thing that's in the E.L.M.S, whether that's motor or speech, what is one thing that would help us then walk into the room with Bill and say, man, I was suspecting either that it's an upper motor neuron damage or it's lower motor neuron, or maybe it's both, but now I'm looking at you and this is going to help a lot. I've seen this and now I know whether or not it's one or the other or both. What's something that's there in E.L.M.S? It's one of the letters that would be helpful. Yes.
Can you go back up to a slide that identifies the acronym E.L.M.S, or is that too much of a gimme?
Hold on, let me see. It might be a bit of a movement.
Sorry.
It's okay. I'm like, I don't even know where it is on here. That's so crazy. I was thinking maybe something I missed. Okay, so here, yes, Madison got it. Motor function. So the motor function is gonna be, yes, so functional mobility. So that's going to be a major thing that you're going to be looking at as you walk in, because you want to know, is it upper motor neuron? Is it lower motor neuron? Is it both? So you're walking in and Bill's fine, actually. So we're gonna jump right to, hold on, let me just do this then. I think this is where we were. Okay, so you actually go in and there's nothing noted about his limbs because he's completely fine. He's able to move his arms, he's able to move his legs, but he has complete left facial palsy. But the left facial palsy is the kind where it's like, it's droopy, but when he's emoting, if he's like frowning, if there's like a laugh response, he's able to get it moving, right? But outside of that, there's a bit of a weakness on that left side. But his arms are moving fine, his legs are moving fine. And so immediately we should already be, our thing should be firing for it. I think it might be just upper motor neuron. So if I walked in there and I'm like, hey, Bill, could you wave could you wave at me? He's waving fine with one hand. All right, what about the other hand? He's like trying, nothing's going on. Then I'd be thinking, okay, there might be something on with lower motor neurons, because they're the ones that are affecting, they're the ones that actually go to the muscles and affect those muscles, right? And so I think an important thing to know, specific with facial palsy, it can get confusing because you're immediately thinking, if they have facial palsy, that means it might be a lower motor neuron thing. However, that's not quite accurate. If it's upper motor neuron, you could still have left facial palsy. If it's lower motor neuron, you could. The only difference is with upper motor neuron, if a patient has some palsy, some weakness on one side there, they'll be able to still emote. They'll be able to kind of get a laugh in, a smile in, a blink in. However, if it's left facial palsy that is attached to the lower motor neuron damage, man, they'll be drooling, they'll have some teary eyes, their eyes are staying open. Like it is completely gone. The motor function is completely affected. So that's a way for you to kind of gauge what's going on still if it's upper motor neuron versus lower motor neuron. Exactly. With stenosis, I'd be curious if motor function fluctuates with his positioning. That's an interesting one. That's an interesting observation. I hadn't even thought of that, but yes. So as you're looking at him, you see complete left facial palsy. He's still laughing a little bit. He has some movement in there. It's just kind of, so still you're thinking upper motor neuron, right? This guy's limbs are all good. This guy's face, yes, it's a little, but he still emotes, which rules out the idea of like, is he drooling? Is his eye not even closing? Like that is the thing that you would think lower motor neuron, along with the limbs, one of the limbs being affected movement. That is what's lower motor neuron. So let's keep upper motor neuron in our head as the damage. And so then you're listening to his speech, okay? So let's not forget too, I don't want to rush too fast, that we did see, oh goodness, did I lose it? What's going on? Hold on, just a second. Okay, so let's not forget this, right? So we've kind of done a little bit of weeding through as we've looked at motor function. We've said, okay, I think it might be upper motor neuron is what these two have affected. But we also still have this, an ischemic stroke that involves the left cerebellar hemisphere. So the cerebellum is also another thing that's been affected. So let's still keep that in our minds as well, okay? So let's jump into here. So we're now back again to his speech characteristics, the one we saw at the very beginning, okay? Now it's starting to make a little bit more sense as we're listening to his drunken scanning speech. His hypernasal, he's harsh, his decreased rate of speech, he has end of vocalization grunt. So let's look at our chart here, because now we're looking at this chart and trying to see, man, what does this guy have? I'll give you a clue, it's a mixed dysarthria, right? So just looking at this chart, you're going to look at the auditory signs. And we're going to think back to what Bill has. I'm trying to figure out, I don't know if there's a way I can pull up both things, but if you have the handout, you should have Bill's speech characteristics on there, or I could just switch back and forth. But now what I want you to do is utilizing what we know as the damage, which is, it is probably bilateral upper motor neuron. Why bilateral? Because it was the R and the L-MCA, which means really where it goes with both sides. The MCA, which is that the blood flow has been affected, so it's bilateral. And then also we saw in the MRI that he had some ischemic stroke in the cerebellum, right, the left cerebellum, but the cerebellum nonetheless. So looking at those two and hearing about those two, and then we're also listening to what we saw for his speech characteristics there. I think people should have an idea, okay, of what this guy has. It's a mixed dysarthria. So based off of what you're seeing here and what we know to be his neurological deficits, which dysarthria does he have? Which mixed dysarthria does he have? You can pop it in the chat and I'll just wait for you all. If it's Elena who answers, I'm going to ignore it because she's been answering. Even Madison, I'm going to just be blind. So it has to be somebody else who hasn't chimed in yet. And we still have time, which is great. So it does give you time. I'm not expecting everyone to jump in really quick in case you're still thinking about it, you're still looking through it. I'll give us a couple of minutes. And if you have any questions, things that you're like, I'm not really sure, go ahead and you can jump in and ask, and I'll try my best to clarify so that when we get to our final diagnosis, it makes sense for everyone.
Pam, you answered to me. You should reply to everybody. I'm going to copy and paste a response. Hold on.
Okay. Yeah, Kimberly, ataxic is one of the types. So Kimberly's got ataxic and we've got the other, because this is a mixed one, right? So often you'll see the mix. Often you're going to see the mix. And I say that only because all the times that I was, just working on, different patients, most of the times they don't have a pure dysarthria. It's going to be mixed with something. So it's something and it's ataxic as well. Okay, so interesting, which Janice says flaccid. Now we're inclined to think that, but remember, Janice, when you walked in, Bill's good. He's moving, right? And the lower motor neurons, those are the ones that really go to your muscles and are the ones that if he had anything affecting his lower motor neurons, he would have immediately had some sort of paralysis or a paresis, and you would already have seen his face all like this, drooling, pocketing food, not closing his eyes. But he wasn't like that. He just had some palsy over here, but he's able to emote. He's able to laugh, right? He laughs and his face moves. It's only not moving when it's voluntary, but he has still that involuntary, and that's how you know it's upper motor neuron. So it's spastic, right? Exactly. Why is it spastic? Because it's upper motor neuron damage and it's bilateral. Why is it bilateral? Because when we looked at the chart and we looked at the CT, we saw that it was L and R MCA that had been affected, which means bilateral, quite literally. The MCAs are trying to get that blood flow to both sides of the hemispheres, and they're not quite able to. So it's a bilateral upper motor neuron damage. So our guy has a mix of spastic ataxic dysarthria. And so that's what he presents with. Patient presents with a mixed dysarthria, spastic ataxic, characterized by drunken stunning speech, which is really the only key one that's attached to the ataxia, right? And hypernasal, harsh, speech with decreased rate, and the vocalization grunt and volume variation. All those rest of them are attached to spastic. So often when I'm writing it down, I'll start with I'll name it, starting with the dysarthria that has the most amount of speech characteristics. Yeah, so often it's like slurring your words, but that's really just what that drunkenness scanning is. And it is that hallmark for our ataxic. So it can happen, and it really usually happens in our ataxic patients. But I've phrased it as drunken/scanning on here. So this is what we have as our results, okay? And so as we're kind of looking at it, let's just make note also of how we then justify that. This dysarthria is evidenced by moderate to severe stenosis involving the RMCA and LMCA, and multifocal acute ischemic stroke involving the L cerebellar hemisphere, resulting in left facial palsy and reduced sensation on the left side. Okay, obviously sensation isn't as pertinent to us because it's a motor speech thing. It's about the motor and what's happening motor wise. Okay, so that's how we would write this, and that's how we would diagnose him. I'm going to leave you all with also this. This is the quality of life in a dysarthric speaker. This is a good patient-related measure. This is a great way to not only measure the patient's progress subjectively, what contributes to the end of vocalization grunt. I think it might have to do, and this is me making an educated guess, but it might have to do with that disruption in respiration, or really getting that full movement of the chest there because of that increased spasticity and hypertone, whereas they're talking and it's like ends with a, it just ends with, it's just a lot of effort that they're putting in because of the fact that they're not getting as much of that dynamic movement, because of the fact that their upper motor neuron is kind of like going haywire, right? So the lower motor neurons are like, okay, facilitate. We're trying to keep muscle tension. Oh, now it's like, there's all this tension, there's all this hypertone. And so then these guys are struggling. They're struggling to really just get that full range as they're talking. So it's really a respiration thing. And then it really affects the phonation. So they're kind of talking like this, and it's a lot of effort, and and so that's just kind of like how I would say as a grunt. Yeah. Okay, I'm glad that was helpful. So like I said, this is a helpful measure that, you know, it looks at different places they could be, you know, on the phone, at dinner, and they can rate themselves from 0 to 4, 0 being not at all, 4 being like all the time. And this is a great thing I would use to just, and it would give you a total number at the end as you add all this ones up. And at the end, you can even show them, hey, you know, you're completing it again at the end, and this is how much you've moved forward. And again, there's also understanding that we're looking as we're treating them, then we know, okay, spastic, respiration, okay, this, then we're looking maybe at phonation, we're looking maybe flaccid, okay, resonance. So all of those things, there's different the methods of treatment that we can do because we understand the neurology and because we understand how they're going to present and we can hear it. So then we're doing specific targeted tasks because we're looking at specific things. Okay, we got a couple of minutes left here. So I'm going to jump into, do you guys have any questions for me? Help. Okay, does this help quantify disease severity from the patient perspective? Yeah, you could say that in a more subjective way. You can kind of understand how severe this is for them, right? And so it's a great way for them to open that. So it could be like, I sound okay, I sound good. But then when you start saying, okay, but what about when you're on the phone? Okay, but what about when you're at a dinner table? Then they're kind of getting more of that understanding of just how bad it is. And it also gives you buy-in, right? Oh, wow, my speech is cool. You know, some people are just prideful and you want to help them, but they're also like too proud to say, I don't sound like I used to. And so this is a good way to kind of be like, well, you know, we could work on that. You know, we could do this. So that's just a great way. Yes. Adding to the grunting can be through the hyperadduction of the true vocal folds, effort speaking, difficulty abducting or relaxing. Yeah, because of the increased tension as well. So that's something that's a great. Thank you, Madison. So does anyone have any other questions? Okay, awesome. I'm gonna also jump into a bit of the reference. They're kind of just put on there towards the end. I was just kind of throwing caution to the wind in terms of APA, but I also included the E.L.M.S Analysis article that's right there at the bottom by Paul Blanchett. And so if you want to jump into reading that, it is pretty helpful as it lays out stuff that we talked about today in a good. The funny thing is I found it at the very end of me creating this whole thing, but it's a good one. And then, this is really just like a textbook online that helps you with understanding upper motor neurons, lower motor neurons, extrapyramidal system, if you still need all of that. And then this was that motor speech disorders paper by Duffy that I talked about. So yeah. And obviously we have, I think, the quality of life. Dysarthric speaker. But thank you so much, you guys, for being here and for letting me give my first ever talk ever. I really enjoyed it, and I hope that it was helpful for you all. Thank you.
Tina Mupambo, you're amazing and you're a gift to our field. And I appreciate you so much. That was huge. Yeah, thank you for your time and energy. Please stay on for the next talks as long as you can. We appreciate you so much. Everyone in attendance, I am going to now post a sign out form so that you can give yourself credit for today's first session of our convention. We will be taking a 10-minute break and we will resume with our next session at 9:40. So again,